To take a deeper dive into some of these specific technologies and their applications to lung cancer, I'm pleased to introduce our second speaker, Dr. Eric John Kovitch. Dr. John Kovitch is a board-certified pathologist involved in the design, validation, and sign-out of clinical next-generation sequencing-based molecular testing at the Washington University Genomics Pathology Services Core. His research interests are in the development of bioinformatic methods in molecular oncology, and he also serves as medical director here at Cofactor Genomics. Thank you for being here today, Eric.
Thank you, Natalie. So I'm going to just start off a little bit and kind of give you guys some background on clinical sequencing, and that is sequencing that takes place in the regulated CAP-CLIA environment. And so I've been involved in clinical next-generation sequencing since about 2011. We started the Genomics and Pathology Services Lab at Washington University. So I'm going to give you a little background about general clinical sequencing, and then we'll go in and talk about some projects that we've been working on with Cofactor for RNA sequencing. Basically, there are really four main reasons to perform clinical sequencing. And so the main reason that most people order clinical sequencing is really to identify potential therapeutic targets. So that would be like BRAF, V600E in melanomas, or targetable EGFR mutations in lung cancer. Probably the second most common reason that physicians would order clinical NGS is for risk stratification. So, for a good example is expression classifiers in breast cancer, gene mutations in acute myeloid leukemia or MDS that carry specific prognostic significance. You may also order clinical grade NGS to confirm a diagnosis. So if there's the histologic diagnosis is in question, and a lot of diagnoses can be difficult to make based on the grounds of morphology or immunohistochemistry alone. So confirmatory molecular testing is common to differentiate two closely related entities. They may be treated differently. So, for example, BRAF V600E in hairy cell leukemia can be used to make a diagnosis and to separate it from, for example, splenic marginal zone lymphoma, which is very morphologically and immunophenotypically is similarly related. MYD88 mutations are also fairly specific for Waldenstrom's macroglobulinemia, and so you can use sequencing to make that to help make that diagnosis. And really the final reason I think that physicians order clinical grade next-gen sequencing is to decrease costs or to speed workflow. Probably the best example of that is exome sequencing of children with developmental delay. You can perform a whole exome rather than piecemeal Sanger-based testing. And it's also very useful for biopsies with limited tissue. So for example, brain tumors like glioblastomas, where we perform a variety of tests. Next-gen sequencing makes a lot of sense because you can identify a whole spectrum of mutations, deletions, and translocations.